Welcome, everybody, and hello. Um, we're very excited for tonight's PEP Talk on decoding the link between autoimmune disease and blood clots. And tonight, Todd and I are joined by really two experts in this field. The first is Dr. Jordan Schaefer, who is a hematologist focused on coagulation disorders. Dr. Schaefer completed his undergraduate degree at the University of Michigan. He received his medical degree from Michigan State University College of Human Medicine, and he completed his residency in internal medicine at the Mayo Clinic. And then returned to Michigan. I think you are a Michigan person by birth. I know you do the hand thing for Michigan, to complete his fellowship in hematology and medical oncology. His clinical interests include thrombotic disorders. His academic interests include health disparities, cancer-associated thrombosis, antiplatelet therapy, and anticoagulation. He is also a member of the National Blood Clot Alliance Council of Emerging Researchers in Thrombosis, and we are delighted to have you with us, Dr. Schaefer. We are also delighted to have Dr. Jason Knight. Dr. Knight focuses on the role of neutrophils, platelets, and endothelial cells in the vascular complications of autoimmune and inflammatory disease, such as antiphospholipid syndrome, lupus, diabetes, etc. He has been published in more than 130 peer-reviewed manuscripts. He is the corresponding author on publications in Science, Translational Medicine, Nature Communications, Journal of Clinical Investigations, and all of the leading journals in the field of rheumatology. He has been recognized with so many awards, I can't possibly list them all, but we can tell you from the American College of Rheumatology and the Lupus Foundation of America. He received his MD from the University of Michigan Medical School, where he completed his residency in internal medicine and his fellowship in rheumatology. And you were really a world leader in many aspects of this area. So thank you both for joining us tonight. We are going to dispense of the doctor name, and we're going to go to first name basis now. So we're going to very shortly kick off with Jordan and Jason. But before we do that, two things. Todd is going to lead us through some poll questions. And I just want to remind everybody, tonight's event is for educational purposes, and it is not to be giving medical advice to anybody. Please, if you need medical advice, speak to your doctor directly. That is not our goal here today to advise anybody, but to really provide educational information so that you're a more informed patient. So with that, I'm going to turn it over to Todd.
Very wise words, Leslie. And I'm going to read you some poll questions. Folks, we do this. We love gathering the data. We want to figure out who you are, what's going on with you. So that's why we ask you these. If you don't mind filling out this poll, and we'll do one at the very end as well. Your first question, do you have an autoimmune disorder? Yes or no? If yes, what is your diagnosis? If you could write that in. And have you ever experienced a blood clot? Yes or no? And number 4, the final one, has your risk of blood clots ever been discussed with you by your medical team? Yes or no? You can fill those out. We're going to go over the results. I want to remind you that all of our PEP Talk episodes, all of them are fantastic. It's like going to blood clot school. They're awesome. If you look on the website and look under patient resources, you will find the entire media library. So that's just something to keep in mind. And we're going to have the results here in just a second. Here you go. The first question, do you have an autoimmune disorder? Yes, 72% of you do. 28% said no. If yes, what is your diagnosis? Those aren't popping up in here, so I cannot read those. The third question was, have you ever experienced a blood clot? Yes is at 87%. 13% of you have not had a blood clot yet, so you must be here for the education, and that's excellent. Has your risk of a blood clot ever been discussed with you by your medical team? Yes or no? Yes, 62%, but 38% said no. So some folks in the dark out there. So thanks, folks, and we'll do another poll at the very end of the show. Leslie?
Okay, thanks, Todd. That 38% number is a little bit disconcerting for folks. Okay,
it is.
So our topic tonight is decoding the link between autoimmune disease and blood clots. And actually, Jason, we're going to kick off with you this evening, but we'd like the two of you to jump in together. So it's a very informal discussion process, and it's great to have somebody who's a specialist in the rheumatology space with a hematologist. I wish all patients had access to that. Um, so Dr. Knight, let's talk about exactly what is autoimmune disease first of all, because this term kind of gets thrown around a lot, and so we'd like for you to just explain to us, what is it? What is autoimmune disease? And this description is so vague. So are there certain autoimmune diseases that lend itself to higher rates of VT? And if so, which ones?
Okay, that's a great question, and thanks for inviting me, Leslie. Your organization is doing a lot of good out in the world, and it's really exciting to be here. Yeah, autoimmune disease, I guess to understand that, you have to first understand the immune system, at least at a high level, and the immune system exists to help us combat things from getting inside our bodies that shouldn't be, things like bacteria and viruses. And as organisms get more advanced, specifically the vertebrate organisms, which we are part of, there's something called adaptive immunity, which is pretty clever. It lets that immune response really get tailored over time to the specific organism that you're trying to combat. Um, the even cleverer thing is that it's able to remember what it's done. So I think we know from vaccinations and past infections that this should help us give protection against the next time we have an exposure. And that's because of this kind of nicely trained adaptive immune system. But in autoimmunity, things go wrong. So you can probably tell from the word, instead of attacking the bad guys like it's supposed to be, it attacks our own body. And so we can look for that in different ways. A common one is to look for certain types of antibodies in the blood that are not protective antibodies, but antibodies that could do harm. And I mean, I think I could just say at a high level, I'm sure Jordan is maybe better at me to talk at the entire landscape in terms of blood clotting risk with different diseases, but antiphospholipid syndrome, the one that my research lab especially studies, I think is the classic example of a autoimmune diseases that raises your risk of blood clotting, and I think everyone would agree with that. Other autoimmune diseases, and that might be a good time to pitch it to Jordan to kind of talk about. I think what I see in the clinic is when we have diseases like lupus or vasculitis or Behçet's disease, and those diseases are active, like the inflammation is really on the attack. I think that's the time those folks carry the highest risk of blood clotting, and so we sometimes might have a clot that happens in the setting of an active disease, but if we're able to get that calmed down over time, we think that's going to give someone a lot of protection going forward.
Mm-hmm. It's really interesting. And does it kind of run the gamut in terms of, when I was first diagnosed with my pulmonary embolism, I went to the hematologist and she came in with her fellow and she looked at me and said, "You have rosacea." And she scared me. And I was like, "Wow, I'm here to talk about my blood clot." And I'm like, "Why is that even relevant?" And she said, "It's an autoimmune disease." So, I mean, does it scan the horizon from something as benign as that to APS as an example?
Yeah, there's certainly a spectrum. And I mean, the tricky thing is there's even a spectrum within these different diagnoses. These are mostly diagnostic buckets that we've had since the 1980s. And, the hope is that over time we get better at kind of refining them and sorting out some of that, some of those differences we see in the clinic. I mean, I think especially we look for the one called rosacea because it can sometimes be mistaken for the butterfly rash that goes with lupus. I have a feeling that's why they were especially having that in their mind, especially if you're talking to a woman. That's something you should be thinking about. But this is something Jordan and I were talking about in anticipation of this. I think it's relatively rare outside of APS that we would recommend testing for all kinds of autoimmune diseases after a blood clots, unless you're kind of guided to do so by the clinical picture. So that's where you hope you have a doctor that's taking the time to listen, not just to your blood clot story, but to the other aspects of your health to see if, some screening testing should be sent, and maybe you do need to see a specialist to rule that in or out. Or, I mean, if there's someone else that's just totally asymptomatic, I think it would be harder to justify that kind of workup.
Yeah. Yeah, sometimes people have multiple autoimmune conditions, and so the presence of one or a strong family history of autoimmune disease can kind of clue you in to look for other things as well as something we'll kind of think about.
No, that's a good point. Todd?
Yeah, and let's expand on this a little bit. Jordan, I'm going to go ahead and ask you if you could just explain to the audience why the relationship between autoimmune disease and VTE? Just explain that relationship. What is that interplay between the immune system and VTE? When we're treating a VTE patient, what would cause you to suspect an underlying autoimmune issue? What would lead you to suspect there might be one at play? How would you test for it? And what would the VTE treatment protocol be like?
Yeah, thanks. That's a good question, and thank you again for the opportunity to be here. I actually prepared a couple of slides that I can kind of go to that might kind of get at the question you're asking and kind of my approach. I'd agree there's definitely a spectrum of autoimmune diseases and how much we worry about those diseases when it comes to both venous, like deep vein thrombosis and pulmonary embolism clotting risk, and also arterial thrombosis. And then, yeah, each patient can be, highly variable in how that disease affects them, and then how that affects, kind of like our gestalt about how much that might impact, clotting risk, as far as how active the disease is. So I'll pull up a slide here. So, and I think one thing is it's important to, this topic doesn't get a lot of attention. I've even, recently been around a group of hematologists where we were talking about the, some general autoimmune diseases and the risk of thrombosis, and said, well, those diseases don't really increase the risk. So I think one of the reasons why this isn't, commonly talked about is some providers may not be aware of it. And then the other thing is that some of those autoimmune diseases are less associated with clotting risk than others, like antiphospholipid. Antibody syndrome is strongly associated with thrombotic risk, whereas some of the other autoimmune diseases are more weaker clotting risk factors and might not really affect, patient management that much. So that could be kind of why this topic doesn't get a lot of attention, but a lot of patients are interested in this and do have a lot of, questions on it. The autoimmune diseases that we commonly are thinking about and looking for, would be definitely antiphospholipid antibody syndrome, inflammatory bowel disease, so like ulcerative colitis and Crohn's disease, vasculitis, things along those lines. And the immune system, inflammation in general has long been recognized as, something that increases risk of thrombosis.
And Jordan, just before you move forward, we
Yeah.
use these words kind of interchangeably, but again, inflammation is what exactly?
Yeah, so that's a good question. So inflammation generally refers to, so there can be like clinical signs of inflammation. So sometimes when someone has a deep vein thrombosis, for example, they'll come in with an inflamed leg. And then why is it inflamed? It can be from the clot. It can be from a clot plus infection. That's when we see, redness, warmth, swelling. Those all things are signs of inflammation. Now, what causes the inflammation in the body? That's often, part of the immune system. It can be the release of inflammatory what's called cytokines or molecules in the body that then your body is responding to. And it can be, there's kind of a complex, mechanism by which your body generates, an inflammatory response, often due to some, trigger. So the trigger could be like infection or a blood clot or something like that. Your body has these mechanisms to respond through an inflammatory process. And sometimes inflammatory processes are short, or sometimes they can be long-term inflammatory processes. And oftentimes autoimmune disease can be a long-term inflammatory process that can increase thrombotic risk over time.
Okay, thanks. Sorry, I didn't mean to interrupt, but
Oh,
just
yeah.
clarify.
So that gets the question, like one of the first things when we're seeing patients is why did they get a clot? Why do some patients develop clots and others don't? And even, within an autoimmune disease, why do some clot and others don't? And often we're looking at multiple factors, and autoimmune disease can be one of many factors that we're kind of think about. And we want to kind of think about, for people who haven't had a clot, what's the risk of getting, so if you have a disease like lupus and you've never experienced a blood clot, what's your risk of having an initial event? And then for, survivors of blood clots, they're often who are more commonly who I'm seeing in clinic, they're wondering, they're worried about the clot coming back. How does this autoimmune disease affect my risk of another clot? And how does that change if I'm on the blood thinner or if I'm not on the blood thinner?
Mhm.
And then part of that discussion is also, is your autoimmune disease, uncontrolled? Is it a disease where your doctor's having to, doctor like Jason has to give you a lot of, medicines to control the autoimmune disease? Or is it a disease that's not well controlled, that's been, kind of causing you a lot of symptoms that have been linked to the autoimmune disease?
And I would
And
just
so,
jump in. I think that's a good place to emphasize inflammation because, maybe you have the disease lupus kind of all the time, but there's periods of time where the body is more inflamed and things are really churning away versus other times when it's a lot quieter, and it's during those inflammatory times that the risk is clearly higher.
yeah.
And just another question. I know you've brought a history of somebody here, a patient, but does inflammation tend to lend itself more to pulmonary embolism, or is it relatively equal between PE and DVT in terms of somebody actually triggering a VTE event? Is there any data around that?
I don't think so. Some inflammatory disorders and autoimmune disorders can affect certain parts of the body. So there can be some kind of association where, if you potentially had inflammation of the blood vessels of the lungs, where maybe you'd be more risk to, but one than the other. But it hasn't really been teased out very well, as far as I'm aware, to that one would be more, DVT would be more risky than PE, because often those can be interconnected. But we always think about the anatomic site about what is inflamed. So for example, patients with inflammatory bowel disease might be more prone to blood clots in the splanchnic vein system, so like portal vein thrombosis or blood clots in the abdomen that you don't really see with other, clots. Antiphospholipid antibody syndrome is one where we worry about both venous and arterial thrombosis, depending on how it's presenting. But yeah, and Jason, your point was also good. Yeah, some disorders like inflammatory bowel disease will have episodic periods of inflammation, like a flare of Crohn's disease, for example. And so how we approach somebody who developed a clot during a flare of their disease compared to when their disease was stable might be a little bit different, because that might, suggest, was the inflammatory bowel disease playing a role in the blood clot? So,
Okay.
yeah, so kind of going, people have looked at, causes, and this is something, that I included this slide mainly just to kind of emphasize that there's a lot we don't know still about these autoimmune disease. I'll talk a little bit about why that is, but and also how to handle the variability between patients. But the clotting history is long evolution of trying to understand why people form blood clots. Historically, at one point, blood clots were felt to be from evil humors. Postpartum blood clots, so blood clots that happened after pregnancy, at one point were termed milk leg and felt to be from unconsumed milk in the leg. And so the treatments at those times would be things like breastfeeding and bloodletting to try to fix whatever they thought was causing the blood clot. Kind of tying into that, if we think that autoimmune disease is playing a role in forming blood clots, we think that it's important to address that as the underlying cause, to follow up with a rheumatologist or a specialist in that autoimmune disease and treat that, because if that's driving the clotting, we want to try to control that. And so inflammation, even back into the 19th century, has been recognized as associated with clotting, and they variously thought that inflammation of the vein wall was what was causing clotting. And so some of the initial treatments for deep vein thrombosis were just anti-inflammatory medications and bloodletting. And eventually a pathologist kind of came up with what is known as Virchow's triad, which is this stasis, so lack of blood flow, vessel wall changes, which is kind of inflammation, that inflammation, and hypercoagulability. And autoimmune diseases really affect, can damage the lining of the blood vessels, the endothelium, so the vessel wall changes, and it can promote hypercoagulability. And that's kind of why those two mechanisms are kind of why autoimmune diseases will be involved in promoting, blood clots. And I won't spend a lot of time on this picture, but there's a lot going on in the clotting system. What I enjoy about doing hematology is this balance between bleeding and clotting, and your body has a complex system to regulate this. If you get a cut in your arm, you want to form a blood clot there, but you don't want to form a blood clot in your leg. So you want to form a clot so you stop bleeding, but you don't want blood clots throughout your body. And so your body has kind of like a gas and a brake to kind of control the clotting system. And autoimmune disease can cause dysregulation. This is an example of some of the way that antiphospholipid syndrome develops, but it can cause some dysregulation of that that balance between bleeding and clotting. That can be we talked about the cytokines. You have coagulation factors that can be increased, and you have natural blood thinners that can be decreased in the body. Some autoimmune disease activates platelets, like the yellow things here, that can be informed in blood clots. You can see these, components, affecting the lining. This is inside the blood vessel. You can have alterations in how your body breaks down blood clots, where it doesn't break down blood clots as well. And there can be a release of what's called microparticles into the circulation that kind of promote clotting. And so, one thing I emphasize with patients is that it's this kind of spectrum where there's these autoimmune diseases that we commonly see, like that patients will have, and that aren't very active, aren't really needing treatment. Those often don't play a role in how we approach blood clot management. Then we have these things that are kind of more in the middle, maybe like sarcoidosis, things like that, inflammatory bowel disease, that can influence management. They are associated with the risk of an initial blood clot and a recurrent blood clot. Have a good association there. And then there's highly prothrombotic conditions, things that make you prone to blood clots, like antiphospholipid antibody syndrome. So it's kind of that spectrum and kind of understanding where you are. And then these circles overlap. So there's some people just the labels are helpful to kind of have these discussions, but there are some people that may be on a spectrum that are more or less affected by their given disease that would push them into a different category.
Well, and to Leslie's point is, I'm trying to not get distracted by the chat that I'm seeing pop up, but I mean, you see how common it is for people to have multiple autoimmune conditions in one person, right? So they don't always read the textbook that kind of defines them separately, but within one person, there's multiple things happening.
I want to just pause here for a second, and Jordan, I want to come back to these slides in a bit, but Jason, given that you jumped in, let's take this a little bit further. So one of the most common autoimmune diseases we hear about relative to VT is APS. And talk to us about that, because that is really one of your big specialties, APS, and the causes, if known, the treatment, how does inflammation impact this? And is it correct that APS is that mostly women get APS? That's something like 80% of all APS known cases are actually with women. And again, why is that? Is it genetic? Is it not genetic? So, and then the other thing I want you to talk to us about, I know I'm throwing a lot of questions at you here, is there aren't a lot of doctors who are specialists in this area. And so how would somebody, if there are research opportunities or trial opportunities, could they get involved in participating?
Yeah, thanks, Leslie, for that multi-pronged question. Fortunately, that one you fed me a little bit ahead of time, so I had a couple bullet points here I wanted to hit. But yeah, APS, we think it affects roughly 1 in 2,000 people. That's based on epidemiology in the USA and Europe primarily. Not super diverse epidemiology, so there is an unmet need to understand in other like non-white populations, especially how common APS may be. So it's kind of right on the cusp. I sometimes say that it's a pretty common rare disease. Like if you want to scoop it up as a rare disease, you can, but it's right on that threshold where For example, Congress defined rare disease as less than 200,000 people in the U.S. affected, and it's kind of right at that threshold. When we make the diagnosis, we look for certain types of antibodies in the blood, which I think and talk a lot about, but maybe not something we need to go into super in depth, but terms you might have heard like anticardiolipin antibodies, or there's a test called lupus anticoagulant. That's another way that we can test for those. I think, again, we don't need to go into it too much, but under the umbrella of APS, I think the most famous thing, if you will, is that it causes blood clots. But we also recognize that, it impacts the ability of people to carry pregnancies to term. And so that's a common one we have to confront in the clinic. And there's also other features.
Why is that?
Well, and so, that we think is a little more like the inflammation of APS versus the blood clotting side of it. The prediction would be, well, the placenta is just filling up with clots, but I mean, what you see is anything that stresses the placenta can trigger some clotting in there, but the work in the research laboratory and the new treatments that are being proposed for the clinic are much more focused on the immune system versus blood thinning per se. But I think that's part of the reason to explain the 80% affecting women, may be slightly higher than what I would have said, but it's definitely tilted towards women. But the fact that there's certain manifestations that, not everyone is at risk for, I think is part of that, because, even though I can list off a bunch of things APS does, that's where the individualization comes in, because not everything on that list is going to happen in every person.
Mhm.
And so there's other things like low platelets and heart valve problems that we have to deal with in the clinic. And then some that are, I hope we can eventually crack the case, but things like brain fog and muscle pains and things that we see in a lot of our other autoimmune patients are definitely something that happens in APS, and definitely things that do not respond to blood thinning medication. So there's unmet need there. My elevator pitch for why we need more research is that it's an autoimmune disease that we mostly treat with blood thinners. So I think we've already talked enough today to understand that there is a disconnect there. I think there's still an opportunity to treat it closer to its source. And that's, I think blood clotting or blood thinners can keep the blood clotting at bay to an extent, but they're still not perfectly effective. And, they do come with risks around bleeding. And so, I'm very hopeful that in my lifetime, we will have much smarter ways to treat APS.
Is there a preferred anticoagulant? Because I see in the support group, some people will mention the doctors are going, no, you can't be on warfarin, no, you can't be on Xarelto, and back and forth with that. Have there been any studies, researching done? Do you have anything to add to that as far as an anticoagulant?
Yeah, it's an important question. So warfarin is so probably most people on this call are familiar with warfarin, but that's a very old style medication. Newer types of treatments have come around. These are ones that doctors call DOACs, which is kind of an obscure term. This means like direct oral anticoagulants, but these are drugs like rivaroxaban or Xarelto, apixaban or Eliquis that have a more targeted mechanism than warfarin, and they are easier to take. There's less need for lab monitoring. Unfortunately, in the early studies comparing these side by side with warfarin, it didn't seem they worked as well in APS. Still the numbers of people that have been put into these trials are, a few hundred, not a few thousand. And I think we don't have the whole story. And I think to say that I think there's a future where we're going to be smarter about understanding which subgroup of people with APS might do okay on these easier to take drugs. But until that moment comes, we generally discourage their use as the first line treatment, that we would like to try warfarin first. And, if there's problems, we can always individualize. But if your doctor is telling you you have APS and shouldn't be on warfarin, that's a doctor that concerns me a little bit, because that's, that's not accurate info. But my patients with APS tell me that they are finally hearing this term pop up in on TV, because when they watch a commercial for some of these new drugs, that's now getting called out as a reason to potentially avoid them. And I think they sometimes feel like they're adrift without anyone recognizing their kind of clunkily named diagnosis. And so I think the word is getting out, but there's likely opportunity to do better with getting that word out.
There's not enough information. Come back to the the implication for women again, and
Mm.
let's just walk through that, why
Yeah.
women are more likely to have
Mm.
APS.
Well, and yeah, and I think in framing the question, you kind of made the point that the fact that autoimmune happens more common in women is not unique to APS. That's certainly something like lupus is the classic example where it's more like, 9 or 10 to 1. Although like APS, when a man gets lupus, it can often be a very severe case. So it's not that like when it pops up in a man, it's going to be a mild case. Not really. This is something that's been researched for some time, and there's still not, I think, 100% answer. An obvious thing to think about would be the different hormones in the body, and there's probably something to that. I think a lot of that risk is driven by relatively younger, or a lot of the disconnect between the risk in men and women is driven by relatively younger people, where those sex hormones are in full play. The newest research is around kind of the X chromosome, which is probably a little wonky. We don't have to go into in detail, certainly, but there was an interesting paper out of Stanford earlier this year where they were studying a gene that is expressed by the X chromosome in pursuit of silencing the second X chromosome. We don't want women to have a double dose of all those genes that are on the X chromosome necessarily, but one of the downsides of this gene expression could be tilting people towards autoimmune. So if we could precisely answer that question, it reasons that we would be smarter about treatment. But as far as you know, there's still not a definitive answer, but it's a pattern that you have to know about and can't be avoided.
So when women are diagnosed, do they tend to be diagnosed at a younger age? And then if that is the case, what happens during the course of a woman's life as she gets older? Does the impact of APS decrease? Does it stay with them forever? Is this something that they pass along to their children potentially?
Oof. Well, yeah, we do get, as you could imagine, and rightfully so, people ask us a lot about like the risk to their family members. I mean, the pattern we see in the rheumatology clinic is really one of autoimmune diseases kind of generally running in families. And I would guess, I'd be surprised if that doesn't resonate with a lot of people in the audience that, you diagnose someone newly with APS and there's a mother that had rheumatoid arthritis or an aunt that had scleroderma. And that's probably that's because there's no single gene that's driving all of this. There's lots of like little genes that play a small role, and probably the more of those you pick up, the more likely you are to be tipped over into an autoimmune condition. I think an instructive example for genetics is twin studies because they're kind of easy to understand. Like, that identical twins have identical genetics, and kind of regardless of the disease, whether it's rheumatoid arthritis or lupus or APS, you see something like a 25% concordance. So if your twin sibling has APS, we might tell you there's a 25% risk in yourself. And on the one hand, that's pretty high. Like if someone told you you had a 1 in 4 chance, that's meaningful. But on the other hand, it shows that there's still pieces that we can't explain by genetics, that things we're getting exposed to in the environment at the wrong time that tricks the immune system. Could be things like smoking that cause chronic inflammation in the lungs, but that's not enough to explain most examples. So that's when we start to invoke certain infections that may confuse the immune system. Maybe some of these chemicals that are in our water supplies. I mean, these are all things to kind of worry about and, what role they may be playing in tipping that balance. If you have a predisposed person that gets exposed to something at the wrong time, that's when an autoimmune disease can be unlocked, I think.
Interesting. Okay, before we go back to Todd and Jordan, someone did post in the chat here. I just want to address it. She was told that her adult children did not need to be tested. So I'm assuming she has either autoimmune or APS, but that her, and I'm sorry if I didn't see the original thread here. If she does, how should she deal with this issue?
Yeah, I mean, that's what the textbook would say and the advice I typically give myself in the clinic, I think. And that's just because no single autoimmune disease, or at least the group we're talking about tonight, run in families strongly enough that we recommend preemptive testing. I mean, we may get smarter and smarter about this, kind of like what we're seeing happen in the cancer field, where it does seem they're getting better and better at, turning genetics into, very specific information about risk. But we're not there. I wouldn't recommend kids getting a big autoantibody profile. I think what is important, that goes back to the point that Jordan kind of made, that I think he was helping to emphasize something I should have said, which is knowing someone's family history does play into how we think about things. And so what I would advise is just making sure family members are educated about that family history, because if something does come up, there is a new symptom, I think that can be quite helpful for the doctor when they're thinking about what might be going on.
Okay. And then, sorry guys, just one more thing. So somebody did ask about if you could address the question that I posed about aging and APS. Women get older, how does their autoimmune illness play out?
Yeah, I think, and I don't know if Jordan has anything to say on this one. I mean, I think everyone's a little different. Sometimes after working with them for a few years, we really find the perfect cocktail of medications to get things in check. And that's kind of the ideal situation. And that's someone that I hope will have just a very excellent prognosis going forward. I mean, we do see folks, and sometimes there's a gap in care or something that happens, and they pop back up 3 years later, and a lot of new things have happened and are worse. And so it's almost like there's so many different patterns. I try though not to be. I mean, I think most folks, we get them on the right treatments, we can expect a pretty good prognosis. So I would not live in fear things are going to get worse year by year, because that's for sure not the dominant pattern that we see.
Okay. All right. Thank you. Jordan, I know we didn't finish your slides and your questions, and so I'd like to come back to you. If we could continue that would be great. And then I'm just curious, Jordan, do you always refer your patients to a rheumatologist if there is an autoimmune issue? And Jason, when you have a patient come in who has an autoimmune disease, do you refer them over to Jason? Like, what is this kind of relationship, or what should the relationship be between the rheumatologist and the hematologist, so that, the people who are listening to us tonight have the right teams in place?
Yeah, that's a great question, and something that often comes up with patients, because some patients aren't even aware that some patients I see aren't even aware of what rheumatology is and what they do, and why would they see two doctors for one disorder? Why can't just one be enough? And it's on a case by case basis. There's some patients that have primary antiphospholipid antibody syndrome. Maybe they've had it for 10 years. They're doing well. There's no suggestion that they have another autoimmune disorder, and maybe they're traveling from a long distance away. They don't want to see another doctor or anything else, and so I'll often follow those patients on my own. But some patients, are this is a scary disease, and I think you've covered in some of your other lectures about the emotional impact that some of these clotting events or pregnancy complications can have. And so a lot of patients I really want to know everything possible about their disease and what they can do to try to optimize their outcomes. And so a lot of patients are interested in seeing Jason when I see them, and I kind of offer that. And then I especially encourage patients to be seen if there's any hint, when I'm talking to them, that there might be, lupus or some other autoimmune disease that might be a piece of the antiphospholipid, antibody syndrome. And so the benefit there is that I can spend an hour talking to them about blood clotting and anticoagulation and those things. And then the autoimmune piece, can be addressed by, Jason and his group. And then we're often in communication. We meet regularly and talk about, some patients and that kind of thing, where if there's, patient where, we need to, talk about their care, we're able to communicate. And there's other rheumatologists that focus on APS at our institution as well. So I don't know, Jason, if you have any other thoughts on.
No, I think that's all right. I mean, I'm kind of blessed to work at a place where we have hematologists as good as Jordan, that low key could probably be rheumatologists also if they wanted to, but leave that lane open for us. But yeah, I think for the doctor side, just the other piece of it is, Jordan was hinting, there are a lot of sometimes difficult decisions to make, and having someone else who knows the person well to bounce it off of is just really valuable. And that's why it tends to be the tough cases that we discuss together, but I think we all learn a lot through that process, and hopefully it leads to better decision making in the long run.
Yeah, and Jordan just said something amazing, which is I can talk to my patients for an hour, which is unheard of in these days. And so making sure you have enough time with your patient is really important. We really want people to advocate for themselves. And so don't be afraid to ask for the rheumatologist or the hematologist or the consultation between the two of them. So, you know, it's your life, your body, your disease. You get the care that you need. Love to go back to the slides, Jordan, with Todd. He had a bunch of questions that I don't think we answered yet. So if you don't mind maybe bringing those back up, that would be great. And then after that, we're going to go into Q&A because we have so many of them.
Yeah, we do.
Yeah, I can quickly just go through a couple more slides, but I'll be brief because I don't want to leave enough time for you know, to cover some questions. But in you know, kind of some of the things we covered, you know, I know some of the things that comes up is, you know, if you have, you know, symptoms suggestive of a diagnosis, you know, how does that approached? And, you know, oftentimes, you know, somewhat in hematology, we're often like detectives trying to, you know, dig through years and years of records. You know, maybe there was a scan a couple of years ago that made it hinted at autoimmune, you know, disease, or, you know, an abnormal blood test that was previously done. You know, one of the reasons it takes a long time to see patients with, you know, clotting disorders is you really have to dig through all the records and their symptoms to try to determine, you know, if there's any pattern to them that can you know, and sometimes if I'm not sure, I'll refer to a specialist. You know, it could be, you know, hey, this kind of sounds like inflammatory bowel disease. You know, maybe let's have you see a gastroenterologist or a neurologist for an autoimmune disease affecting the, you know, central nervous system. And then for people with an established diagnosis, which is probably more common that I'll see somebody that has a known autoimmune disease, you know, I try to work with their specialist in their autoimmune disease to get a sense of how active is the disease and is there anything else we could do. You know, sometimes I've got some patients that have autoimmune diseases that have affected their ability to take pills. So we have to take that into account when we're picking an anticoagulant. We might have to do an injectable, like low molecular weight heparin instead if they're not able to, you know, take oral medications. And often people are on multiple medications. We have to think about drug interactions and how to select the best anticoagulant for a given patient. We try to answer for patients, you know, how does their diagnosis affect clotting risk? And, you know, does treatment of that condition kind of improve that risk? And so, you know, some of the things I'm trying to sort through when I'm seeing patients, you know, why did they get a clot? You know, do they need to be on an anticoagulant? If they do, you know, how long do they need? Which anticoagulant is best? That's what we're talking about a little bit of the warfarin with antiphospholipid antibody syndrome, you know, is often recommended. And then some of these disorders, you know, one thing patients, you know, might not realize is that some of these disorders can be associated with an increased risk of atherosclerotic disease or plaque buildup in the arteries. And so for some autoimmune diseases, I'm really encouraging patients to be following up with the primary care doctor as well, make sure the blood pressure is controlled, cholesterol is controlled, those kind of things, because, you know, following patients for years, we don't want to, you know, have them develop other kind of problems in other, you know, vascular areas other than the deep vein thrombosis or pulmonary embolism.
I don't know about you, Todd, but I did not know that. Nobody has ever actually mentioned that to us, that
No.
they should be checked for that as well. What is that correlation?
Yeah, so some diseases are associated with an accelerated rate of atherosclerosis, and so sometimes I'll be, you know, asked to see patients who are relatively young, and you know, whether it be on scans or invasive image, you know, diagnostic tests, that they have a lot of you know, plaque buildup in the arteries, and sometimes that can be associated with an underlying autoimmune process. Again, these are generally like the stronger autoimmune kind of conditions that we'll see, which can kind of be, you know, unique from arterial blood clots otherwise, or cardiac intracardiac blood clots. But when there's been articles that have, you know, some of the science is kind of early on this, but it was some of the diseases. But if there's a suggestion, you know, that they're at increased risk for heart disease or those kind of things or peripheral arterial disease, you know, I tend to encourage, you know, when I send a letter to their primary care doctor, I tend to encourage the primary doctor to try to optimize all those risks. And we want to do that anyways, because, you know, some of these things are also bleeding risk factors, you know, so some people
Right.
have nerve damage, you know, from their autoimmune disease, and they have a risk of falls. So we talk about, you know, what can we do, physical therapy, you know, make sure their vision is corrected, those kind of things, so that they don't have any falls. If they have, you know, their vasculature is at risk, you know, we want to make sure all that's good. And then it's part of just kind of controlling, you know, blood clot risk as well. So I'll skip over these, but some just general recommendations to kind of close up my section. It's good to build your team of doctors that you feel comfortable with. This can often be whoever's prescribing your anticoagulation, but primary care doctor, rheumatologist, gastroenterologist, neurologist. Sometimes people are unsure about recommendations. Like we're talking about the DOACs, you might consider getting a external input, and then kind of optimizing bleeding risk and health. And often these decisions aren't like static. Every time we come in, we're kind of reassessing, well, how have these symptoms changed over time? How has your clotting risk and bleeding risk evolved over time? And so these are some things you might ask your provider. Some people, it's understandably an anxiety-provoking time when you go through a blood clot. And so, sometimes, people say, well, I want to be tested for, every possible, condition. We have to be kind of selective because there can be some downsides to over-testing too. So we kind of focus on what are the tests that are going to change what we do for your care to improve your quality of life, duration of life, and, any symptom you're having, is there something we can do to make that better?
And just a question for you in terms of treatment, though. If somebody has a blood clot, they come to you, and then you want to test them for APS or, frankly, any other autoimmune disease, do you have them come off their blood thinner? Or can you do all of this testing while they're on the blood thinner? Does it in any way influence the results?
Yeah, that's a good question. In the mainstream testing for antiphospholipid antibody syndrome, there's there's three main blood tests. Two out of within that, they'll come back as separate lines of testing, but two out of the three can generally be done on anticoagulation, the antibody testing. The testing for the lupus anticoagulant is often, subject to interference by the anticoagulant. So, it has to be kind of individualized on how providers, kind of approach that. Sometimes, it's been tested before they start anticoagulation, and then you have a sense of, you got an accurate measurement of that lupus anticoagulant. For patients that are already on an anticoagulant, it kind of depends on the details surrounding the clot and the given patient on how we approach that to see, because we don't want to leave patients unprotected from anticoagulation and risking a clot while we're trying to establish some other diagnosis beyond the clot itself. So yeah, that is a good one, and there's a couple different tricks that we can sometimes come up with to sort that out. And so yeah, I'll skip over the rest of these slides. I'll just say there's a lot of challenges with autoimmune disease and thrombosis. Some of these disorders are rare. Patients are affected differently. They're on different treatments, and oftentimes it's the characteristics of the clotting event itself that guide management rather than, so was it an unprovoked pulmonary embolism versus clot provoked by a surgery or something like that. It's often that distinction that affects management from a hematology point of view. But we're always looking for, are there other things that we need to be thinking about, when making a care plan? And ultimately, patients' preferences and bleeding risk are often factors that we have to, think about. Patients often have multiple things going on, and we have to, that's kind of what the fun of it is, trying to work with patients and trying to find a care plan that works for their, given circumstance.
Well, so I'll tell you what, as far as care plan, I just needed something that worked, right? After 6 blood clots and being homozygous factor V Leiden. And I've proven a couple of different times that I clot in 3 days if I have no anticoagulation in my system. So I'm just thankful that, it doesn't work for everybody because each anticoagulant is going to be different. Everybody's going to have a different experience. But I've been on Xarelto for 13 years and it's done a great job. And I'm certainly not going to try to fix what's not broke. But can we jump into some questions? Because that got me to thinking. Jordan, I wanted to ask you, a lot of people talk about diet. So we were just talking about, your care team. And I got to tell you, 2 of the most important specialists on my care team was my therapist for the post-clot PTSD, which was bad. Yeah. And a nutritionist, because I knew I needed to lose 100 pounds and I didn't think I could do it on my own with no education on nutrition. But we have questions come in all the time. into the support group, is there a certain diet? I don't even like using that word, but is there a certain nutrition plan that helps with maybe inflammation? Is there a certain nutrition plan that is best for blood clot prevention? You know, it's kind of general, but do you have any feedback on that?
Yeah, that's a good question. So for a lot of my discussions, it kind of will involve what anticoagulant patients are on. I do like to have a good list of what supplements people are taking and what alternative, because more and more I'm seeing patients are on some alternative medicines that they didn't discuss, and some of those are
Right.
significant. So I really like when you're giving a medication list. I really like to know I actually specifically ask patients anything else you're taking, recreational drugs, alternative medicines, those kind of things. I'd like to get that whole list. And if it's something I'm not sure of, I send it on to the pharmacist and have them do a detailed, dive in the drugs. On the foods, right, having a higher weight or body mass index can be associated with clotting risk and recurrence risk. And so, that dietary component is good. So some of that, maintaining a healthy weight and getting if appropriate and no other reason that you can't do like exercise in general exercise. I think those are all good things to do to promote long-term health and venous health. We talk about that as well. Specific dietary recommendations, though, mainly for the warfarin treated patients. I'm sure people have heard the vitamin K piece of that. Otherwise, I don't, that people, I do have patients that like ask about anti-inflammatory type diets and diets that affect inflammation, but it's not something I routinely advise. And if anybody's doing any, kind of extreme diet practice or something that's more unusual, I kind of like to know about it. If people don't get iron in their diet and they become anemic, I kind of like to know, well, I don't get any iron in my diet. I'm vegan, for example. I kind of like to have that in my notes so that way, if I see that blood test come back and the hemoglobin went down, that I know, well, maybe that's the reason. Otherwise, if there's some other things that I'll watch for more nutritional deficiencies and those kind of things, but I don't have a certain autoimmune diet that I recommend.
What do you think about fish oil? So doctors tell their patients, no fish oil, and then there's some doctors go moderation. Mine said I don't take supplements, but I get a ton of fish, swordfish, chia seed, flaxseed, all that. How do you feel about that?
Yeah, that's a good question. So, fish oil has been used for potential lipid benefits, and so sometimes often I'll see patients that are on that related at the recommendation of their cardiologist. There's a spectrum of fish oils, like in terms of dosing. Like there's prescription level fish oils and kind of higher doses that people end up on. There's been some link with the bleeding risk on some of these, but that's been questioned in some other studies. So it's not something I hugely worry about if people are on it for that reason. But if they're high bleeding risk or they're having some kind of bleeding issue, I'll kind of take a look at that and make sure that's part of that medication review to make sure that there's nothing that's potentiating that, because it was at least at a time some association with some of the fish oils and a slight increased risk of bleeding. So.
Great, thanks, Jordan. Leslie?
So we've had actually quite a few people have written into us about Hashimoto's disease. And some of them have had several blood clotting incidents, and some haven't, but they're very concerned that they may have a blood clot at some point in time. Anything to share about Hashimoto and the correlation to blood clots, and if the folks that haven't had the blood clots, should they be talking to potentially a hematologist about going on a blood thinner? Is there anything out there on this topic?
Yeah, so as far as preventing an initial so Hashimoto's is one of the more common autoimmune disorders that we'll encounter when we see patients, as it's being one of the more common conditions overall. It's not one that I commonly think about when I'm thinking about thrombotic risk. I try to make sure that their patients are following up on it with a doctor that manages Hashimoto's and those kind of things, that their thyroid is managed. Otherwise, there's not, to answer your question, there's not really much. We don't put people on I haven't ever put somebody on a preventative antithrombotic agent, so anticoagulant or antiplatelet agent, just for the reason of Hashimoto's itself in isolation. Maybe there's some other circumstances where somebody would want to discuss that with their doctor, but that wouldn't be typical. And then for the risk of clotting, there's mixed, my understanding is that there's mixed literature on, thyroid disease. You can find studies out there that, associate, thyroid disease with different types of outcomes, but it's kind of a mixed, mixed picture. Some studies show things and other studies don't really confirm those. So that's why it's kind of, on the provider end, it can be kind of unclear, what to do differently beyond that from me.
And for just to follow on to that, so for some of these folks that had written in that have actually clotted, they wanted to know if they should be considered for higher doses of medication. That their maintenance should be higher dosed anticoagulant forever. Does the concept of decreasing the dosage over time exist, or if you've had multiple clots and you've got rheumatoid arthritis or Hashimoto or whatever it may be, will they stay on a high dose anticoagulant typically for potentially forever?
Oh, so this is you're getting at more like the dose reduction after 6
Yes.
months, you're saying? Okay.
Yeah.
Yeah, that's the extension trials where they kind of looked at, initial management of a patient's blood clot and then reducing the dose of apixaban, which is the trade name Eliquis, or rivaroxaban, trade name of Xarelto, reducing the dose after a period of time. There was a set criteria of, who was included, and it wasn't very, the people included in those trials weren't extremely high risk of clotting, but they weren't extremely low risk either. And so, this is one that, I'd encourage people to talk with their, doctors about and kind of sort out on their individual risk factors, where sometimes we're kind of looking, well, do you really match up with the people that were included in the study? But the study is in the hundreds of patients, not in the thousands, and didn't have, extremely long duration of follow-up, because, some people, I'm sure in the audience, have dealt with clotting issues for years, whereas these studies are often more in the spectrum of months. And so, there's some discussion that needs to be had on what the optimal dose of anticoagulant is for a given patient based on their specific profile and characteristics.
Okay, thank you. Todd, ladies' choice. I get one more.
Well, something that like I said, I'm just connected to a lot of the patients in the group, and something that I've seen recently is some doctors have put their patients on a DOAC plus low dose aspirin together. What's the reason for that? Is there more danger of bleeding with that? And is just being on a low dose aspirin, is that helping with arterial and deep vein prevention, or is it just arterial? How does that all work?
Yeah, that's a great question, and that's actually one of the things that I'm interested in, and in doing research kind of on that combination about which patients should be on an anticoagulant and an antiplatelet drug, which does increase bleeding risk. But the idea is, especially vein clots are often treated with anticoagulants. Some other clots are treated more with antiplatelets, and oftentimes people have a reason for both. You might have one disease that's often treated with an antiplatelet, which affects the platelets, and another disease that's affect an anticoagulant related drug. So a common example is coronary artery disease in a patient with venous clotting, and should it be combined? And so it's an evolving area. Is that the same for warfarin and an antiplatelet drug compared to a DOAC and an antiplatelet drug? And if the DOAC dose is full dose versus preventative dose, and it ultimately kind of depends on what is the reason for the anticoagulant drug and what is the reason for the antiplatelet drug. They do increase bleeding risk, but there are some situations where combination therapy is an individualized consideration. There's some where it's guideline directed therapy that they should be on, after like a heart stent or something like that, often people, and then there's some people where, we look at this and it's like, well, you probably don't really need the aspirin, so maybe we can talk about, stopping that. So yeah, that's a good common issue. We found about a third of patients that comes up that they've been prescribed both, and
Wow. Okay.
yeah, so
Okay.
it's not uncommon that we'll see, people on a combination therapy, and we try to do a detailed, dive into their history to kind of see whether that's appropriate or not.
Sure.
It's important to make sure your doctor knows you're on the aspirin, because sometimes it doesn't get on the list, given that it's
Yeah,
over the
good point.
counter.
Good
So,
point. Thanks a lot, Jordan. That was great.
That is a good question. Okay, what is the relevance for persistently lower intermediate levels of APS antibodies in a patient with a previously established autoimmune disease but no history of clots? Jason, might that be?
Yeah, I mean, I think it's there's not a simple way to answer that question, except that I do think the profiles matter. Like, we can see a profile that we say is a very high risk one, and it's not the same as potentially more borderline antibody levels in no one that's had a problem before. So we should not treat all of those results as equal. And hopefully you're working with someone that can see some of that nuance and use it to help help guide treatment. But yeah, I think it's a savvy question and one that we need to keep getting smarter about.
Okay. All right. In the interest of time, Todd, I think we should take maybe 2 more questions, and then we have exit polls. I want to be mindful of Jason and Jordan's time this evening. So why don't you take one? I'll take one, and then we'll go to poll questions.
Yeah, pretty easy. Another popular question just from the last couple of days. I don't know how you guys feel about that, and either one of you can answer or both. Got to talk about smartwatches just real quick, and I want your opinion because we have a lot of people that are depending on these things. I have one. I love wearing it. I use it for certain things, but you can also check your vitals with it, or it says that it'll keep an eye on your vitals, let you know when something's wrong. How do you feel about smartwatches? Can they be used as just like a general guide? I mean, I know that I use mine for sometimes calorie counting, maybe for track stepping. I don't know if I pay too much attention to my O2 or anything like that, but I do use it quite a bit. But how do you guys feel about smartwatches and people using those?
I think it's not a replacement for a doctor quite yet, although who knows if that's coming in the future. But yeah, I'll be interested to hear what Jordan thinks. From my perspective, I think more information usually better than less information, as long as it's not being taken as the stone tablets, but instead as part of the puzzle. But
Okay.
Yeah, kind of along that. I've had a lot of patients that have found them to be useful to track, markers of their health and that kind of thing over time. I've had occasionally heard of patients where, it alerted them to an abnormal heart rhythm and they got that checked out kind of thing by a cardiologist, and it was useful in that sense. And then, but on the other end, right, it's not, entire reassurance, right, where you can completely skip, if you have a concern, you still need to, seek medical attention, as, depending on what the concern is. Some people I've had where they're, they're looking at the smartwatch and their heart rate is okay, but it's kind of, still sometimes good to have, be evaluated by a clinician if you have a symptom or concern that needs
And those with really high anxiety, or just after a clotting event, especially, I mean, our anxiety is already high, and looking at some stats that may or may not be totally accurate or describing what's going on, that can just raise that level even more. But thank you guys.
Yeah, that's a good, right, that's true.
Okay. Are there any new trials that will start collecting data with APS and secondary diagnosis that I could participate in? I not being Leslie Lake, but I being the patient who wrote this. Are there any trials out there that people can participate in?
yeah, I think we're seeing more and more in this space. We have a few trials that are active at Michigan. If you look up APS research labs, you can easily find our lab website. Most of those require someone to be on the ground somewhat nearby to what we're doing. But I think something that Jordan and I are both interested in is looking for opportunities to engage, to use technology like we're using tonight. Like, I think we can get smarter about how to engage peoples all around the world and find ways that they can participate in research, even if we can't easily give them a new fancy drug or, draw their blood. I think there's still other opportunities. And I just see it reading. I mean, it's humbling and also motivating to read this chat as it's going across just yeah, I think we've all got to do better with getting the research to get answers to your questions, and then also getting the word out there. And they're both unmet needs that need hard work.
I love it that they're hungry for information. I mean, that's the way I was when I started with my clots. It's like I couldn't find any information at all. If it wasn't for reaching out and finding the MBCA, I wouldn't be where I'm at today. So people are hungry for the information, and we like to give them the accurate information.
So before we go to the poll questions, we do want to tell people that we're sorry that we can't get to everybody's questions, but there were so many of them. We're actually going to take them and we're going to try to create responses to them. It's going to take a little bit of time because there are so many, but we will endeavor to do better in this space and provide people with more information because it is so important. And I'd like to put Jordan and Jason on the spot and say, will you come back and do this again? Because it is such, it is uncharted territory still, I think, for people. And there's a lot of information to yet share. So we would love to have you come back again.
Absolutely.
I could do this every Tuesday if you wanted.
I'll
This is
do it every
great.
Tuesday with
Think
you.
about this stuff all the time. It's great to have
Next
someone that
time.
wants
New
to hear it.
questions all the time.
Awesome. We would, no, seriously,
My
we would
wife
love
and
to
kids are like, stop talking about blood clotting.
we understand that. But thank you very much. You've just both been incredible.
Yeah,
and
thank you both.
And we really do want to have you come back. And with that, people did want to know if they can have access to the slides, actually, Jordan, that you had shared. That would be great if you're okay with that.
Yeah,
Then
I can send you a short version.
okay, then we'll make that available to people. So thank you for that as well. And then Todd, let's close it out with you.
Yeah, and then and if anybody wants to rewatch this in a couple of days, this thing's going to be live in our library.
I'm
So
going to
we have,
rewatch it.
oh, I am too. It's a
this has
learning
been
experience for
incredible.
all of us. So make sure you check out the PEP Talk library because there are just lots of episodes in there, tons of information. We're going to go ahead and give you the exit poll questions now. When those pop up, I'm going to give those to you. After today's webinar, how knowledgeable do you feel about blood clot prevention and signs and symptoms? Novice, beginner, intermediate, advanced, or expert? And one last question, what resources would you like made available to you? If you guys don't mind writing in your answer, we'll compile that data because we want to know. We thank you so much for being with us. I'll give you the results here in just a second. Don't forget to check out the Facebook Blood Clot Support Group, Team Stop the Clot. We've got almost 7,000 members. We're talking all day and all night, so I hope you are able to get in and check that out as well. Still don't see anything quite yet.
Yep.
There we go. Okay, after today's webinar, how knowledgeable do you feel about blood clot prevention and signs and symptoms? Novice, only 4%. Beginner, 13%. Intermediate, 52%, kind of right in the middle. Advanced, 27%. 4% expert, like you guys. What resources would you like made available to you? We don't have those answers, but maybe those will be available.
I think those are for NBCA to decipher.
Okay.
And we did have somebody who would like to have a link to the APS trials as well. So Jordan or Jason, I don't know if you have that in front of you that you could share with people. Otherwise, please send it to us and we will make sure to share that with everyone as well.
Yep, I'll send you the best info. Yep.
Wonderful. Thank you, everybody.
Thanks, everyone.
Good night.